This is a case of a post-operative patient who has undergone a weight loss surgery for morbid obesity. So the information given to you is that this is a 130 kilogram patient with a body mass index of 48, and I must tell you, you must therefore know how to calculate the body mass index, which is straightforward. Patient has had a laparoscopic sleeve gastrectomy and today is day 2 after surgery. Patient is mobilizing already, so that's good news. Patient has been started orally after gastrographin study. This information is also given to you. Patient is having a pulse rate of 78 and a blood pressure of 120 by 80 millimeters of mercury. The port sites are looking all very healthy. There is a drain in situ on the left side of the abdomen. There is a urinary catheter also in situ. And you have been told that you are the resident on duty who has come to see the patient. Tell us how you will proceed and what kind of assessment will you do at the bedside. So as a resident, you need to make an evaluation. So let's start from the basics. Always do assessment of airway followed by breathing followed by circulation. It's always that order. Now, generally, why do we say that? Is because in any sick patient, it is not just in the emergency. Please follow that protocol everywhere. Whenever you see that patient anywhere, always make that assessment in this particular sequence. Airway, because that kills before breathing, because that kills before circulation. So in that particular order. So this patient looks to be very stable. Patient is verbating, patient is talking. So you would look at the patient, you will say how comfortable the patient is with the parameters that have been given to you, that the pulse rate is 78, there is no tachycardia, blood pressure is very well maintained. You would like to, obviously the patient should not be on oxygen, and patient is maintaining on room air, and you would possibly say that I would like to see this patient to be in a propped up position, because these are large volume patients, and when they are supine, their large abdomen pushes the diaphragm up and reduces their pulmonary capacity by pushing the diaphragm and reducing their vital capacity. So you would like to get the patient up and mobilize, try to have the patient in a more upright 30-degree inclined position, and you would do a quick vitals assessment which shows that the patient is doing well. You would see the abdomen, which looks, would assess the abdomen, and you would like to palpate and see the abdomen is soft. It is not very easy to examine abdomen which is very big abdomen. You cannot elicit acute signs. So, but you can just make some idea that the abdomen is not at least distended and it is not very tender. So you would look at from that point of view. Your inspection tells you that the port sites are all looking very healthy. The drain is just having about 20 to 30 ml of serosanguinous fluid. The urine catheter is having almost a light colored lemonish urine. You would check for the intake output. So always say that you would check for the intake output chart. Now these patients are big patients, and you would have given 100 to 120 ml per kg in the 24 hours, and you would like to see whether there is any excess loss, or the patient's intake and output is well maintained. And with that information, you would, with the fact that the patient has already been started oral clear liquids because the gastrographin was done, which shows that the gastrographin would have shown the passage of the contrast nicely. Let us see how it looks. So post-operative patient of a sleeve gastrectomy would be, this would be the staple line, and then after that is the normal course. So you look for no leak, and you look for smooth passage distally. So that's a test that has been done already. And so the examiner may ask you, how do you start the patient orally after this particular surgery? So you will say that after having done a gastrographin study and after having clearly maintained, objectively proven that there is no leak and there is no obstruction in the system, you would start the patient slowly on clear liquid, which is about 50 to 60 ml per hour for the first day, escalated to 60 to 120 ml, twice that amount per hour for the next 24 hours. And then for the first week, you would like to keep the patient on clear liquid diet and then escalate the patient to liquid, which is thick liquid diet, and progressively puree, smoothie kind of a thick liquid, and then pulverized semi-solid diet for 2 weeks, and then semi-solid diet for 2 weeks, and then about 6 to 8 weeks later the patient comes on to its normal diet. So that sequence you should be able to tell.